Welcome, everyone, to the Timmy Talks podcast. I'm Nick Marston here with my co-host David Berg, and on today's show, we'll be joined by interventional cardiologist and clinical trialist Dr. Rasha Al-Lamee to discuss the management of angina and the ORBITA-2 trial. Well, good afternoon, David. Hope you have been enjoying your National Heart Month here in the U.S.
Yeah, that's right. February is National Heart Month, and February always seems to fly by. But I have to say, it's a really important opportunity for us to pause and just think about the impact of cardiovascular disease. Obviously, in this podcast, we take deep dives into the science that supports new cardiovascular therapies, but really just to reflect on the profound impact that these therapies have had on the trajectory of cardiovascular disease is always really humbling.
Oh, absolutely. And today we get an extra day. We're actually recording on the 29th, the leap day. And so extra day of Heart Month this year, which is always nice. And I thought we could do a little history lesson with a quick pop quiz if you're up for it.
Okay, sounds good.
All right, good. Yeah, I always like to kick the tires on that Stanford education. So here we go. So Heart Month. So do you know what president declared the first American Heart Month?
American
I
Heart.
also accept, I suppose, like the year or even decade if you want to go there, but president would really be kind of for full points.
Okay. I don't, but I guess maybe I'll venture a guess. How about Jimmy Carter?
Oh, Jimmy Carter, great guess, but not correct. Lyndon B. Johnson, LBJ, declared the first Heart Month. So that was in December of 1963, making February 1964. 60 years ago, the first National Heart Month here in the U.S. And I think what's actually most interesting about that is right after he declared it in January of 1964, the Surgeon General released the first ever government-issued report that linked smoking to heart disease and to lung cancer. So certainly a pivotal time in history in terms of cardiovascular health.
That's a good factoid. I like that. And of course, Heart Month has really expanded and grown in a number of important ways, one of which has been the advent of the Go Red for Women campaign, which was championed by the American Heart Association. And although that was initially an American effort, it really has become a multinational effort to recognize the impact that cardiovascular disease has on women in particular.
That's right. And speaking of the AHA, we are going to use this episode to highlight one last trial from the AHA scientific sessions this past November. We've done multiple great trials since AHA. And before we shift to ACC on our next episode, we are excited to highlight one more trial. So why don't we go ahead and intro our guest?
Yeah, that's exactly right. And we're absolutely thrilled to bring on Dr. Rasha Al-Lamee, an interventional cardiology consultant and a clinical trialist at Imperial College in London, where she studies coronary physiology, invasive vascular assessment, and coronary intervention. She's particularly well known for her leadership on the ORBITA and ORBITA-2 trials, and the latter of which we'll be talking about on today's episode. I hope you enjoyed the discussion. Well, welcome to the podcast, Dr. Al-Lamee. It's great to have you on the show.
Thank you so much for having me. Please call me Rasha.
Oh, thank you, Rasha. It really is great to have you join us, and thank you. We're going to have a great discussion today on ORBITA-2, but before we do that, we always like to learn about the trialists. And so we're hoping you could share a little bit about yourself and your career in interventional cardiology and clinical trials and any pivotal experiences along the way.
Yeah, no problem. So I'm an interventional cardiologist and a clinical academic at Imperial College in London. I started as an interventional cardiologist some years ago, and really initially was driven to interventional cardiology because I wanted to be able to fix things. I wanted to be able to look after relatively young patients and feel that I could make an impact. But actually, I was also quite driven to the fact that it's an incredibly evidence-based field. And I like to be able to use research and academic medicine to try and improve clinical care. And in terms of clinical trials, well, I guess my first experience of clinical trials was doing a fellowship with Antonio Colombo in Milan. And I went there for a clinical fellowship, but obviously also to learn a lot about research. And it was there that I learned how much research can be embedded in clinical practice and how you can try and aim for almost every one of your patients to be recruited into a clinical trial and to help you think about future innovations and also using the data that we have to change practice. And then I guess my most sort of pivotal moment in my career was when I decided to do a PhD. And I chose to do that at quite an unusual stage. I chose to do it after I'd finished cardiology training and was already qualified as an interventional cardiology consultant. But rather than go straight into clinical practice as a consultant, I took 4 years out in the end to do a PhD. And that PhD was to design and lead and conduct the ORBITA trial. And I guess it's from there that I decided that actually I didn't just want to be a clinical cardiologist. I wanted to be a cardiologist that combined clinical medicine with academia. And that's, I guess, where my career changed.
Well, that's a great trajectory. I have to say that for a PhD project to turn into the ORBITA trials,
Yeah, seriously,
that's a pretty high bar. That's pretty amazing. So,
I remember at the time a very eminent academic cardiologist saying to me, he said, "You're definitely going to become an academic, aren't you?" And I said, "Absolutely not," because I thought academics were these stuffy, very kind of quite arrogant, often a little bit autistic characters. And by the end of ORBITA, I went, I think I might become an academic, but I hope it doesn't mean I've turned into one of those characters.
No, I mean, I think that some of the themes that you commented on certainly resonate with me. I think the nature of cardiovascular medicine being an evidence-based field and being part of a community that really values generating evidence, I think that was certainly an attraction for me. And I think the opportunity, like you said, to contribute to that is really powerful.
Thank you.
So, I think we're here today to talk about the ORBITA-2 program, which was presented at the American Heart Association Scientific Sessions last November. But of course, we can't really talk about ORBITA-2 without the context of the original ORBITA trial. So I was wondering if you could start us off by reminding our audience what ORBITA was all about and what were the unanswered questions in the field after ORBITA was published.
Yeah, no problem. So, I mean, ORBITA came about from a moment in the cath lab, actually. So myself and my soon-to-be PhD supervisor, Darryl Francis, were in the lab. We were doing a case. I still remember it. I was doing angioplasty to a very tight circumflex lesion in a patient who was very symptomatic. And we were at the stage then when he didn't need to scrub in the lab. So I got on with it, did this case. I came outside and I said, well, that's gone well. And he said, well, yeah, but how do you know it's going to work? And I said, oh, she was very symptomatic. She'll definitely get better. And he went, oh, have we really tested that? And then we started thinking about it and thinking, actually, it's never been tested adequately. And the only way to test a intervention that pertains to improve symptoms is to test it against placebo control. And so he kind of then set down the gauntlet, really, of trying to put together this trial. And of course, I mean, he didn't have a lot of experience at the time in terms of clinical trials, and neither of us had run a placebo-controlled trial. And so I then designed ORBITA. And I suppose the question was, does angioplasty improve symptoms in the context of guideline-directed anti-anginal medication? But in fact, I think the legacy of ORBITA has been more than that, I think, in my kind of humble opinion. I think it's actually set the stage for thinking much more about the application of a placebo control arm for trials of interventional procedures and what that means for the questions we can answer, but also the robustness of the data that we get. And for me, that's actually been the legacy of ORBITA. Of course, as you remember, the results were incredibly controversial. I absolutely thought this was going to be a slam dunk for angioplasty when we designed it. But over the years, as I was conducting the trial, it was interesting because people were coming back and they were being coming back for their blinded assessment, and they were being seen by the blinded team. And then when they were being unblinded, a lot of patients were surprised. patients who'd had placebo were suddenly surprised because they'd guessed that they'd had angioplasty, and vice versa was happening. And after they were unblinded, I would do a follow-up call with them to see how they were doing and what they wanted to do in terms of routine care. And I started to become more and more shocked by the number of patients who guessed wrong. And I started to think, God, do we know for sure that this thing's going to work? And, the results obviously were a surprise to the wider world when they came out. And defending those results has been quite a challenge. Led on to thinking about what ORBITA got right and also what we could improve upon in thinking about the next trial.
So I completely agree. I think that ORBITA set the bar very high in terms of what a placebo arm should look like in an interventional study, and we'll come back to the notion of sham controls in just a little bit. But but certainly, I think ORBITA addressed the question of whether PCI was better than optimal anti-anginal therapy for relief of anginal symptoms or functional status. And so then how was ORBITA-2, how did ORBITA-2 come about, and how was that different from the original ORBITA trial?
Yeah, so I think what was interesting in ORBITA-1 is there was this big sense that ORBITA-1 was negative for angioplasty and it hadn't worked. But in fact, as we started to look at the data, and we published this in our first of the secondary analyses, there was definitely a proportion of patients in whom, once they had angioplasty, albeit in a blinded trial, they were free from angina the very next day. And we saw this, and we saw that 1 in 5 more patients were likely to be free from angina. So there was some proportion of patients that for whom the effect was immediate and sustained and kind of absolute. And then there was a bigger proportion of patients in whom maybe there was some reduction in angina. For some, it got worse, that kind of gray area. So then I started to think about, well, how do you predict which patients are most likely to benefit? And actually, we then started to think about the trial design, and I modeled ORBITA-2 very much on the kind of evolution that we've seen in renal denervation. And my feeling was that once you start people on an anti-anginal agent, and once you give them more and more anti-anginal medications like we did in ORBITA-1, and the average patient was on 3 anti-anginal agents, there is an improvement in symptoms in some patients. And probably it's those patients who have significant epicardial disease that's causing their symptoms. And I started to make this joke. I said, maybe if you give people a beta blocker or amlodipine and they feel better, it's those patients that are most likely to benefit from angioplasty, not the patients that you give all these anti-anginal agents to and still have residual chest pain, because maybe those patients didn't have cardiac symptoms to begin with. And so the question was, well, how do you test the therapy works without the attenuating effects of other therapies? And so to do that, in my opinion, you had to take them off anti-anginal medications and just test the unattenuated efficacy of angioplasty. Now, obviously, there were other things that changed. We could, because we were no longer optimizing patients in terms of their anti-anginal medications, but making sure that they were on the right risk reduction medication, we didn't have to have that 6-week run-in phase. And so we were able to buy back time and therefore increase the length of follow-up for 12 weeks. We were also able to widen the population from just single vessel disease to multi-vessel disease patients too, because ORBITA-1 had proved it was safe to do that. And importantly, we selected a different endpoint. And that endpoint was also based on the learnings from ORBITA-1. So what happened after ORBITA-1 is, I think, in the UK, but actually across the world now, there's more and more emphasis on involving patients in our trial designs. And we developed this ORBITA focus group who I got to know very well. And I was chatting to them about ORBITA-1. And many of them said that exercise time for them didn't really reflect their symptoms. Their exercise capacity was limited by all sorts of different things. And for them, the questionnaires also didn't totally reflect their symptoms. So they wanted to think about an endpoint that made more sense to them. And that endpoint was some capture of their daily symptoms. And initially I thought about just doing this as a paper diary like they've done in previous trials, and particularly in the old-fashioned era of the initial anti-anginal drug trials. But because of the new technologies we have out there, I decided that we could actually do this with a smartphone application and just measure this on their phone every day. And that was obviously a kind of key component of why ORBITA-2 was different, because we were able to get much more data, over 66,000 data points. Every single day for the trial, we had a data point for the patients, and that gave us much more sensitivity to understand the results.
Well, that's very interesting to hear. I mean, it really is a unique trial design and as well as data collection. And there's a number of elements here that are worthy of discussion. And being a trials podcast, we want to get into those. So the first one that I'm particularly interested in hearing more about is, the active removal of anti-anginal therapy in the 2 weeks prior to randomization. Then this is a group with severe coronary stenosis, established ischemia. I'm sure that there was a lot of discussion about this, and certainly there's value from experimental design standpoint to do this, but I'm curious if there was angst from the leadership team, any concerns coming from IRBs about removing therapies that have been shown to help patients in this trial.
Yeah, well, there was definitely angst. I will tell you, I'm sure Daryl won't mind me saying that when I first told Daryl, he said, "You're going to take them off anti-anginals." And I went, yeah. He was like, okay. And he usually lets me run with things, and obviously he's been a mentor to me, but now I'm leading a trial on my own, designing it on my own, and getting on with it. And interestingly, as I started to think about this, I thought, well, actually, I'm not really even being as brave as the renal denervation trialists, because anti-anginal medications have no prognostic benefits. We obviously decided that if someone was on a beta blocker for heart failure or rate control from atrial fibrillation, they'd have to continue it. But ultimately, if we could find an alternative anti-anginal agent for most patients, so if they were on amlodipine and I could put them on a different antihypertensive medication, then it was actually very reasonable to do that. And in the end, unlike in renal denervation, where you're taking patients off antihypertensives and potentially may see events, these anti-anginal agents don't have that risk associated. So the only risk was that they were going to have pain. And if they had pain, we needed to be able to mitigate for that. So we had a 24/7 call helpline with blinded physicians on that helpline. And for every patient, what we did was develop at the outset, when they entered the trial, a schematic. And I was involved in the personalized patient protocol with every single patient. So myself and my fellows decided what anti-anginal agents would be introduced in this patient if needed. Because of course, once they went into the blinded phase, this was protocolized, and we needed to make sure that no one came back to check with me as a potentially unblinded person in the trial. So that was enough for the ethics committee. And in fact, as an analogy for the ethics committee, we used the analogy, or I did, of paracetamol for osteoarthritis. These are pain relieving medications. We need to be able to mitigate the fact that patients might have pain and allow them the ability to restart anti-anginals within a protocol. And importantly, we would capture those events and they would form part of the endpoint. So we'd understand if, for example, there was an increased risk of doing this. And that was a key part for the Data Safety Monitoring Board. They needed to also understand that if they thought too many anti-anginal medications were being restarted and what we were doing was not acceptable to patients, then of course they had the ability to stop the trial.
Yeah, I mean, it's incredible attention to detail, and sort of, I'm sure the sort of coordination from your entire team to sort of adequately ensure the safety of all the patients in the trial is evident, and an important piece of this. I want to pick up on two things that you've raised about the trial design. One being the sham control, and then one, the endpoint and the sort of the unique endpoint you designed. So I guess we'll start with the sham control. And you said that is, I think, probably one of the biggest legacies of of ORBITA is that you were able to effectively implement a sham control. I wonder if you might comment on why a sham control was particularly important in this study design, and how you and your team approached the consent process, how you talk to patients about this, because I can imagine that would be a little bit delicate.
Yeah. So you hear me probably use the term placebo a lot as opposed to sham, and I kind of do that deliberately just because I think the word placebo is much more acceptable to patients and to physicians, and it makes them think about a scientific control arm as opposed to something that's, false or bogus or whatever you might look up when you look up other terminology. So in designing the placebo control arm, I guess the key steps were, how do you maintain a very rigorous high level of blinding, but also balance that with the potential of risk? And in my mind, you have to do quite a number of steps of the procedure to make sure that the patient's blinded, but also importantly, that the medical teams outside are blinded. So, if you have a placebo arm where you just nick the skin and pretend that you did a radial angiogram, it's highly likely that the patients will fathom that. But also, most importantly, the nurses outside, then, they understand, they know the difference in hemostatic control for a true angiogram versus an angiogram in which we didn't do all the steps of the procedure. It was also important to be able to pass catheters, to expose patients to radiation so that they would hear the machinery going around in the room. It was important to give them heparin, and actually it was important for us to do physiological assessments. So that was an easy way of doing something extra that was beyond just a diagnostic angiogram, and therefore increased the interventional steps, but also gave us very important research data. In terms of blinding the patients, they obviously had to wear headphones, they were listening to music. I actually initially in ORBITA-1 was considering a blindfold, but actually in the UK it's unethical to blindfold a patient for a procedure, so we couldn't do that. And then in order to maintain blinding, we decided to deeply sedate them, although with conscious sedation, so they were not needing ventilatory hemodynamic support, but use incremental doses of benzodiazepines and opiates to get them to the point at which they were asleep. And that was key, actually. They also, importantly, I felt we needed to be able to test blinding and to be able to report that, because that's missing from a lot of trials. And so in both trials, we reported the blinding index for both the patients and the medical teams at the point of discharge and at follow-up, so that everyone outside could also, when reading our data, decide whether we adequately blinded the patients. So when I went to ethics, I was totally expecting that they would say, this is the first trial of its kind. The UK is not used to trials like this. I was very much expecting a kind of, a pushback by the ethics committee. But they were so interesting because they said, they asked me a number of questions, and they said, do we know for sure that angioplasty works? And I said, no. And they said, does angioplasty potentially have procedural risks? Does it have long-term complications? And I obviously said yes to both. I said that they're small risks, but they exist. And then they genuinely asked the question, well, why has no one done this before? And I was like, well, that bit I can't answer, but we can do this here. And so then it was all about the patient information sheet and the GP information sheet, and making sure that at all points patients knew that they had a 50-50 chance of exposing themselves to risk without any potential benefit. And then I guess if I come to the point about speaking to patients, well, actually it was really funny because in both trials we had somewhere between 50 to 60% across the trials of patients who were eligible actually agreeing to take part. So while it is hard to speak to these patients about this trial, and this isn't one of these trials where you can just come in, quickly consent them and off you go. This is not a stent A versus stent B, don't worry, they're similar devices, but we're just testing them kind of trial. This is something where you have to invest time. But if you invest time and explain and win over patients' trust, and then explain the research, we've had lots of success with it. And what's really interesting is in ORBITA-2, what we were able to do was have a series of questions from patients from ORBITA-1 who were willing to speak to patients if they wanted a patient perspective. What was it like to be part of a trial like this? Are the doctors telling me the truth? Should I agree to be part of it? And it was interesting because we expected there to be some uptake, but there was really very little uptake in that. Patients were happy to hear from us. And as I said, the vast majority agreed to take part. So I do think it's possible. I think you just have to kind of involve them. And what is really interesting is that the patients, in the vast majority, really enjoyed being part of it and kind of had this sense that they were in this very closely monitored team. So yeah, I think that's something that I'm quite proud of. And we were obviously able to take it from 5 centres to 14 centres and really increase the number of centres in the UK that were part of it.
Yeah, I mean, it's remarkable and humbling to think about the contributions of individual patients to cardiovascular research, right? And really kudos to your team because in the end, I think it comes down to trust and the feeling that you are looking out for their best interests. And so really congratulations on that.
Well, thank you. But I mean, we said this, I remember there was a key part of my fellow's presentation at AHA, which was the kind of last line of it, in which I said we had to do this. So we thank the National Health Service of the UK for kind of enabling this sort of research. And I still do believe that that's where we are really lucky to work in the UK, where we have a unified health system. We have this kind of buy-in into clinical research. And I think that makes it easier for us, right? It's easier to talk about how much you can give into the system when you're taking out of the system for free, essentially. And that's part of the trust that we get from our patients, but also what they give back to the system to make these things happen.
Yeah. Well, one more question for me, and I know that I'm being greedy, Nick. So thanks for thanks for letting me get all mine questions in. So you talked about the new angina symptom score that you created, and I think many people who haven't gone through what you did may not really appreciate the rigorous methodology that goes into developing and validating new questionnaires to measure health status, and that there's really a lot of science that goes into that. And so obviously like you said, there's a number of tools that are already out there to quantify anginal burden. And so, I wonder, and you commented on this a little bit already, but what was, the motivation for developing a new one rather than just using the Seattle Angina questionnaire?
Yeah, well, so that's obviously, it's funny because when you look back now, it looks like you kind of had a crystal ball, but actually that I would say is one of the riskiest things of ORBITA-2. And I remember thinking about this and thinking, well, we have exercise time. That's what the FDA and the European Medicines Agency wants at the endpoint for anti-anginal drug trials and interventional trials. That's why we used it for ORBITA-1. And then we have these validated questionnaires, and are we really just going to go, there's something new? But in fact, when you look back at the data, you realize that all of not all of them, but a vast proportion of the original anti-anginal trials used an angina diary. And the basis being that the gold standard is what a patient tells you their pain is every day, or their symptoms are every day. And actually, when you go back to the source, there's not much validation needed. You need to be able to tell people that you collected it adequately, that it correctly identifies their symptoms and it records them, and that patients are compliant with that. Beyond that, there's no more validation really needed. Whereas when you get quite far away from that gold standard and you're developing your own questionnaire that you're giving to patients at selected time points, or you're putting them on a treadmill, then of course you need to see if that has a relationship and what the association is with the original source, the gold standard angina diary. And so for us, the smartphone app obviously needed to be tested, and the patients helped us to develop it. It went through many iterations before we started the trial, and we had to make sure that that was something that they would fill in and complete, and we had to have a checks and balances system for reminders, and all of that obviously we published at interim points during the trial. The other bit I think that was key was I remember speaking to our statisticians, who were Matthew Shunshin and Frank Harrell from the US, and I had this concept that I wanted to I was calling it the angina mace. I said we needed to be able to put more into the score than just their symptoms, because the patient group told me over and over again that the burden of medications that they took was really important to them, and that if they became free from angina but were taking tablets forever, that wasn't great, because a lot of them spoke to the side effects of their tablets. And so I thought, we don't really capture this. We might capture it as a secondary endpoint on its own, but we never seem to capture it in the primary endpoint. So the concept was, how do you incorporate anti-anginal medication burden with symptoms? And then, of course, within that, it would be good to encompass some of the harder endpoints, acute coronary syndromes, unblinding because of unscheduled angiography, because of unacceptable angina, and of course, death. And so then actually Frank said, within the COVID trials, we've been using ordinal scales. And actually what's fantastic about those is we get an ordinal scale, a point on an ordinal scale for a patient every single day for the entirety of a trial. And that gives you the ability to really increase the sensitivity of your analysis. And so we came to that score. And that's where we thought, this hasn't been used before, but that doesn't mean it's not accurate. We thought about it a lot. We, in terms of working out, because you obviously have to decide what's worse for a patient, the meds or the symptoms. What's worse for a physician? Do they think the meds or the symptoms are worse? And in order to do that, we surveyed lots of physicians and lots of patients. We published that as well, because we had to decide what the kind of sequence was of increasing severity on that score. And obviously we kind of had to validate that again ahead of being able to publish the results. And I think, I hope we see that in future trials, because I do think it gives us much more information.
Well, thank you for giving us such an inside look into the design of these trials. I mean, it's really fascinating. It's really what we love to talk about here. But I suppose we should move on to the results here at some point. So,
Yes.
so I'll pivot us to the results. And if you could just summarize the primary findings for us in ORBITA-2, and if there were any surprises that you had when you first saw the data.
Yeah, so I mean, look, the primary result really showed that if in this placebo-controlled trial of patients essentially off anti-anginal medications with single and multivessel disease, the angioplasty improved the angina symptom score, very significantly so, versus a placebo procedure. The bit that I think was surprising was that this was all driven by a reduction in anginal frequency, and that in fact the amount of medications prescribed in both arms were very similar. So the number of times patients called us with chest pain or symptoms and the blinded team needed to give them anti-anginal medications was very, very small and not different between the two groups. I guess the bit that wasn't surprising to me, because I very much thought that this was the case in designing ORBITA-1, but that was important, was that the effect of angioplasty, when it was effective, was immediate, the next day, and sustained. And so that concept that people had with ORBITA-1, that the follow-up length of the trial wasn't long enough, was actually not correct. And in fact, if you see a benefit of angioplasty, you see it straight away, and it's sustained, albeit for 12 weeks. Longer follow-up than that we don't have. But there's no need to keep them blinded in that trial for a very, very long length of time. We had them blinded for 12 weeks, but in fact, we could have done a shorter trial, just like ORBITA-1, and had them blinded for 6 weeks.
Yeah, that's an important point. When PCI works, it works immediately and is long lasting. So that's important for our patients. One thing that caught our attention was the proportion of patients in both arms who continued to have angina at the end of the study period, despite anti-anginal therapy plus or minus PCI. And so there's been a lot of discussion about why that might be, perhaps microvascular dysfunction or other things. And we were curious about your thoughts about why some patients continue to have angina despite all the interventions we throw at them.
So this is really, I think it's quite interesting, isn't it? Because the rates of patients who have residual angina are already very much stated in the literature, and usually they lie between sort of 30 to 40% from the trials that we've seen before, but of course that's unblinded. The rates seem to be higher in ORBITA-1 and ORBITA-2, and I wonder if that's because it's a blinded trial, so you can't give them, you give them some level of placebo, of course, and both arms have the same, but you can't give them full placebo because you don't tell a patient that they've had angioplasty today. You've told them you're in a blinded trial and you may or may not have had angioplasty today. So whether they hedge their bets and they still report symptoms that they might otherwise ignore, I don't know. But for sure, across all of the data outside of ORBITA, residual symptoms persist. And we see it in clinical practice. We see lots of patients come back to us. And like I said, there's this proportion of patients where it's like a switch. Symptoms are gone, I get my life back, I'm back to playing tennis. And then there's a proportion of patients who just keep coming back. And that bit of the story, I think we hope to be able to come to with the first of the secondary analyses from ORBITA-2, which we're going to be presenting at EuroPCR, which looks at the first set of analysis of predictors. Is it possible to predict the patients that have most symptom benefit? And the first of those analyses focuses on the symptoms themselves. Can we, in clinic, work out from speaking to a patient whether theirs are the symptoms that are fixed by the procedure? And the other trial that we presented at the same conference is the ORBITA-STAR trial, which is a different trial. It's an N of 1 trial where in the cath lab we try in blowing up a balloon in a coronary stenosis to assess whether the pain that they get in the cath lab is similar to the pain that they walk around with in their real life. And it's an assessment of whether reproducibility of pain in the cath lab, it's placebo controlled, we have placebo balloon inflations, whether that can predict whether the stent helps them. And I hope that that leads us to understand who angioplasty works in. And then I think we're left with that big question, what are the residual symptoms? So I think a proportion of that is going to be non-cardiac chest pain and us just associating symptoms with a stenosis because we see it in the lab and we know we can fix it. And then maybe some of it might be microvascular disease. But remember in ORBITA-1, those patients all had very high levels of anti-anginal medications, which should, to some level, improve microvascular disease, and it didn't seem to. And also, what's important to remember in both trials is all patients had near resolution, or all patients in the PCI arm, had near resolution of ischemia. So it's obviously not significant microvascular disease that we can assess with our stress echocardiography. So I don't know. I don't know what these residual symptoms are. And some of it, I think, is going to be non-cardiac.
You know, I was just listening to all this and I was thinking at the beginning that it's so nice how if you the puzzle all sort of hangs together. We had courage, then we had ischemia, then we have ORBITA, and now ORBITA-2, and this was really kind of the icing on the cake. Now I really understand the story, and then as I'm just listening to you talk right now, I realize there's actually so many other questions that I think are still out there that for us to really understand coronary physiology and what actually makes people have symptoms. And I guess as you see sort of ORBITA and ORBITA-2, what do you think is the message that cardiologists should take away from this? And then maybe what do you think are the one or two key things that we need to go from here?
Yeah, thank you. So look, there's one message. One message is when an intervention might have an impact on a subjective endpoint, so angina, quality of life, breathlessness, weight loss, something that patients will report differently on different days, different patients will report differently, and different physicians will assess differently, then I think you've got to have a placebo arm, even if it's an interventional procedure. And importantly, when you know you can blind the patients and the trial teams and the medical teams outside. That's, I think, probably my biggest take home. But for stable coronary artery disease, I hope that ORBITA-1 and ORBITA-2 have produced data that guideline committees and patients and physicians and healthcare providers can use to think about 2 treatment pathways. The first treatment pathway is the ORBITA-1 pathway. Patients come in with symptoms, you give them anti-anginal medications, you hope that their symptoms are relieved. If they have persistent symptoms, then obviously angioplasty is an option, but actually the residual benefit of angioplasty is probably quite small. And then the ORBITA-2 pathway, which is a pathway where you try to select which patients you might give angioplasty to up front. Now, I don't think that that's every patient with stable coronary artery disease and symptoms, and I hope it doesn't lead to a runaway story of lots of patients having stents. But I do think that there's some patients, as I said, who have that kind of light switch, immediate relief of pain when they have good angioplasty. And I think for those patients, if they can tolerate the dual antiplatelet therapy, if their procedural and long-term risk is low, and if they're keen to have a procedure as opposed to medications, I think it's okay to offer that to them up front, albeit with the caveats of obviously a decent conversation about the risk. And that's where I think the messaging should be now.
Yeah, well, thank you so much for taking us through these trials, and really, I mean, thank you for asking these questions, designing these trials, and getting these results, because they really have helped guide the discussions that I know I've had with patients in the clinic who have angina and ischemia and deciding medications versus stents. I think these trials have allowed for kind of a much richer patient decision making with a physician, and kind of allow us to go the way that the patient prefers. As we close up, we always like to ask the trialists if they have any parting words of advice for our listeners, who many of which are early career scientists, academics, and trialists trying to make their mark. And so if you have any advice, that would be really helpful to hear.
I don't know if I've got words of wisdom. So I would say, I mean, as trite as it sounds, don't be afraid to answer questions that interest you. I remember when we were originally designing ORBITA-1, I spent quite a lot of time promoting the trial design and presenting that at various places. And, the reception I got was funny. Some people said, I don't understand, why you're doing this. Like, of course, we know the answer. Other people thought it was really groundbreaking. The most interesting response I had was someone stand up and say, this trial is unethical. Now, of course, this is before the results, right? This is years before. And I said, I was ready, I was always ready with the answer of unethical. No, let me talk to you about the ethics committee and how we did it and the consent form and that process. And the guy said, no, I didn't mean for the patients. I mean for us. This is our livelihood. And then I said, and this is in front of hundreds of people, and I was genuinely speechless. And as you can tell probably from this podcast, I'm very rarely speechless. So I was like, I don't have an answer for that. Of course we need to be able to test what we do, and we need to be able to push the boundaries. And I mean, so many pioneers for hundreds of years before me have been doing it. So I don't think anyone should be put back by that. And then the final thing I guess I would like to say to people is, when your trial results are not popular, I remember getting some very good advice, because that's actually quite hard. I mean, you're a clinical academic. I mean, I just finished a PhD. I'm absolutely not ready for the world to come and attack me about my results, and very important people who I respect and have never met before suddenly knowing my name and not being happy with what I've done. That's really hard. And I remember a really great word of wisdom that I had from a mentor of mine, who said, all you have is your results and your data. And if you believe what you did, and you know that this is just the truth of the results, because of course you stand by that, this is not fraudulent. This is just the genuine results that you got from your research. Then all you can do is tell everyone the results over and over and over again. And I tried very hard to do that. I tried hard to distance my opinion from the results. I tried not to be defensive and just to keep saying, this is the results. And that's probably a kind of important point for all of us clinical trialists. It's so easy because you're very invested in your trial, right? That trial, I mean, ORBITA-1, I often refer to it as my first, I've got a son, and then ORBITA is my second baby, right?
Yeah.
And you do feel defensive because you designed this and you cared about it, and you cared about the patients that were part of it. You believe in the results of it. So it's hard not to take it personally, but in a way you kind of have to take it. You have to take yourself out of the equation and look dispassionately at what you did and think about what you'd do differently if you did it again.
That's really good advice. Yeah, do good work, good science, and then let the results speak for themselves.
Yeah.
I think that's certainly a good takeaway point. You've covered ORBITA-2, and you've alluded to trials upcoming, ORBITA-STAR, and we see ORBITA-COSMIC on the ACC late breaker schedule. So that's exciting. We know this is really just the beginning, and you're figuring this all out for us, and really appreciate you walking us through this. And I'm sure we'll have you back on at some point to answer the remaining the remaining questions here regarding coronary physiology in patients with stable angina. So thanks so much for joining us. It's really been a pleasure.
Thank you so much for having me. It's been great.
Thanks so much, Rasha. Well, that was a really awesome discussion.
Absolutely. I couldn't agree more.
I thought it was, first of all, awesome to hear about just the genesis of the ORBITA trials. But I was also just struck by her comments and how thoughtful she is, and particularly about her patient-centeredness. I think everything from the design of the trials and the language used with respect to placebo control versus sham control, and just the focus on patient-reported outcomes. I think she brings that patient-centered approach to her study design and her scientific approach.
Agree. We really brought the methodology, design questions, and she obviously had thought about that a ton. Loved talking about it, explained it so well. I also thought that just hearing about her kind of career trajectory was really interesting and inspiring. She had kind of become full faculty, interventional cardiologist, realized she wanted to do clinical trials, so kind of hit the pause button, went back to training, back to get her PhD, 4 years to be able to run clinical trials. The ORBITA trial was part of that, obviously. But I just think that's a good lesson for trainees and young faculty, that taking the extra time, even if it's measured in years, to develop new skills, it's going to pay off. It's going to make your trajectory kind of go along at a much faster clip. You're going to get where you want faster, and you're going to, I think, be more satisfied in your career. So really inspiring interview. She was awesome to talk to. Yeah,
I think a lot of both personal and scientific lessons, I guess, is a way to say that.
Yep.
So another great discussion, and that sort of caps our recap of the key AHA trials. Be sure to tune in a month when we'll be previewing the American College of Cardiology Scientific Sessions trials. Look forward to seeing you then. For the Timmy Talks podcast, this is David and Nick signing off.
Thanks for listening. The Timmy Talks podcast is hosted by Dr. David Berg and Dr. Nick Marston and produced by Kate Brennan. Like and follow us on Apple Podcasts, Spotify, and Google Podcasts, and follow us on LinkedIn and X @Timmy Study Group to be informed about podcast news and upcoming episodes.